And as you're prescribing, accountability does rest with the person who signs a prescription. Other people can't annotate your prescription afterwards and countersign it. A doctor can't add another item on after you've written a prescription, and equally you can't do it to theirs. It's good. It's important that you use a prescription pad if it's of FP10 that's got your name on it. You can't use another person's. And I know some people may see that happening differently in general practice, but that's not for nurse, midwife or allied health professional prescribers. We write with our own pads with our own names on. Responsible. You are responsible for the prescribing decision. You're accountable for that decision, and you take the responsibility. It should really be someone that you've assessed and not second-hand message, oh, can you write a prescription for this person? You should have assessed that patient. There is an exemption, if you like, on that for the district nursing service where large teams are working. There may only be one or two prescribers in that team. It's not humanly possible for that independent prescriber to keep going around every time someone needs a repeat prescription. But the NMC in that instance say it must be clear that the writing of prescriptions by the independent prescriber must be in the patient's best interest for continuity of care, and they must have assessed the patient in the past, and they must have clear lines of responsibility for and delegation for their team, where they can trust the review of the members of the team that are feeding back to them. Because, as I said before, they sign the prescription, they are fully accountable. They can't say, oh, well, my auxiliary or my staff nurse told me that this was the state of play now with this patient. They still got to be absolutely 100% happy to write that prescription. If they aren't, they shouldn't be writing it. And if you suspect any adverse reactions, side effects, you have a responsibility equally to report them. You may think, oh, this is a common side effect, but the more reporting that goes on about side effects, the greater strength that side effect has. It may be a rare side effect, but the more people report it, it bumps it up to be a more common side effect. So reporting is your responsibility as a prescriber. So adverse drug reactions, ADRs. A very important message here is only to prescribe if there's a clinical need and you're absolutely certain that you want to prescribe, and that's always the case in any prescribing situation. It becomes even more heightened if you're prescribing for children or the elderly, where their physiology increases the risk of adverse reactions. If a patient is pregnant or breastfeeding, equally only prescribe if absolutely necessary, and make sure you've checked the implications for that drug either being passed on in the breast milk or being transferred to the baby in utero. Always ask if there are allergy history. Don't ask, are you allergic to drugs? Ask about allergy history. Ask an open question, because it may be certain food products which have implications for a drug you're prescribing. It may be other products you haven't considered that they are allergic to. So always try and ask an open question. It should always be asked, and it becomes more difficult for those working in a situation where they've got an electronic record in front of them. The allergy history springs up. They feel they don't have to ask it. I would say they're wrong. It's good practice to always ask, because if someone's acquired an allergy, or whoever took that original record has never asked the question, and you prescribe something and they have an anaphylactic reaction, it's traced back to you, and you've not asked the question, you are fully accountable. So always have it as part of your mantra in your initial assessment when you're talking to the patient. Do you have any allergies? Equally, as part of your mantra, you should ask about drug history. You may have it flash up on the screen, so you think, oh, I know what patients' drugs are because it's all there in front of me. But you don't know what they're taking over the counter, what they're purchasing from the local supermarket. You don't know what herbal medicines they may be taking, complementary medicines, and they may have an implication for what you want to prescribe. They may be taking illicit drugs, and it's a hard question for some people. Some people feel uncomfortable asking, are you taking any recreational drugs? Are you taking any illegal drugs? But you've got to think, if you don't ask those questions and there's an impact in terms of what you're prescribing, you again hold accountability for that. And alongside this, hand in hand comes documentation. So important that you record that you've done this, that you've asked for allergy history and a comprehensive drug history. So you're therefore covered if something should happen and patient didn't divulge information but you've asked the question. Think about the age of your patient. Think about their renal or hepatic function depending on the drugs. You may need to check blood test results. You may need to get a blood test taken before you prescribe a certain drug. Very cautious in the under 12s, very cautious in the elderly because of the pharmacokinetic issues with the physiology of an older person or a very young person. And always, as a rule of thumb, prescribe as few drugs as possible, particularly when we were looking at the elderly where adverse drug reactions are more common, polypharmacy is more common. So think very carefully before you prescribe a drug. Are you prescribing to counteract a side effect from another drug? Start low with dosages, build up, go slowly. Always take every consultation with a patient as an opportunity for a medication review. Only prescribe drugs you're familiar with. Sounds common sense, but it can be something, particularly if you're in a situation such as general practice where you're seeing so many conditions across a whole range of patients of ages. General practice is what it says. It's general practice, so you can see anything and everything. That doesn't mean that you should be prescribing for anything and everything. And I have heard of cases where nurses working in general practice have been pulled up by prescribing leads for prescribing across a whole range of drugs throughout the B&F, which they can't possibly be competent to. Sometimes that can be pressure from others that they're employed by to run clinics that they don't feel comfortable, but they feel they've got to because their employers ask them to run clinics or to prescribe, or more commonly to prescribe repeats for patients to save other people having to do it. It shouldn't be what you're being used for. Remember what we said earlier, you sign the prescription, you're fully accountable for that decision. So you've got to prescribe what you're familiar with and not to prescribe what you're not. And that's so important for your own protection as well as the patient's protection as well. And don't try and hide potential reactions. If you know there's a common reaction, for example, if you're prescribing ACE inhibitor ramipril, explain to the patient that they may have a persistent cough, an irritating cough, and that they should let you know about it. Don't try and hide side effects. For example, if you're prescribing selective serotonin reuptake inhibitor, you know that they may have some gastric symptoms as the drug levels increase in the body. If you warn a patient about a side effect which will go after a few days, they're more likely to comply with the medication than if you'd actually withhold that information and don't share that with them, because they'll think, oh, I don't like these side effects, and stop taking it. Because some side effects become tolerable. Some side effects, unfortunately, are what has to happen for the benefit of the drug. So there's a cost, not only the cost and efficacy decision, but there's the benefit versus side effects decision to be made sometimes when you're prescribing as well. But I think it's important that you engage with patients as partners and share that information with them. So I mentioned record keeping. So we've got the we've referred to the NMC record keeping guidelines here, 2010, because they're very comprehensive. But I suspect if you look within all of your codes of conduct, there's reference to record keeping and protecting you as a professional and a certain conduct you should have. Make sure your records are accurate, that they can be read, that they're legible. I know there's a lot of places, particularly in the community now, where we're using electronic records, which overcome some of that problem. Make sure they're not ambiguous and contemporaneous, which means that they're written as near, if not at the time, that you are prescribing. That's always not humanly possible. It should be done as near as possible to when you prescribe. if you're if you're prescribing, for example, in a community setting and you haven't got access to the shared record immediately in the home, then make sure that you do annotate the shared record with what you've prescribed, and that has to be done within 48 hours or 2 working days by law. And the reason for that, why do you think that's the case? Why should it be done so soon? So have a think about if you were to prescribe something and it didn't get onto the records, particularly if it was something that the patient was trying to get, for example, an antibiotic from you. They were absolutely convinced they needed an antibiotic for their cold, and you advised just some symptom relief and prescribe that, or you didn't prescribe anything. They go trotting off, leave your clinic and go round back to the reception and book in to see the doctor. And if you've not updated the record, the doctor doesn't know the discussion that's gone on, or doesn't know what you may have already prescribed, and you may be contraindicated with something they wish to prescribe. So it's very important that the record is a one record that's contemporaneous, so the patient is safe and everybody knows what's going on. Equally, if you're working in a team and other people may follow on in terms of managing a patient, you need to make it clear in your records what you've prescribed, your rationale for prescribing, and it may seem quite long-winded what you've got to write out, but it's better to be safe, to be clear, your rationale, the dose that you gave and why you gave that dose, maybe why you gave a drug that wasn't the first line choice, your rationale, so it's clear to others following on, so that the patient receives a seamless service. Make sure your record keeping is relevant, that it's not going off at a tangent, it's relevant to what you need to record about why you've prescribed. And there's sufficient detail, it's not too brief. You must date and sign, obviously, print your name if it's not clear who you are, and you should always time records. Certainly the NMC record keeping for nurses and midwives indicate all records should have a time of writing, and in the record you should include a time of when you saw the patient, so it's very clear. The date the prescription's written, if that is not the date that when you write the record, should be clear within the record. And make it clear the name and profession of that prescriber in the record, so you may want to write after your name and signature that you're an independent prescriber, or you're writing in supplementary, or you're prescribing a supplementary capacity, for example. And not to forget what you've already written on the prescription, the name of the drug, the dose, the route, the formulation, duration, etc. Make sure that's all there. Now have a think about other professionals in terms of their record keeping. Do we all write the same records? Do we all write the same information? What are the implications for maybe some of your peers who are from a different profession, what they may write on their records? So have a think about that. Ask around with other people who are prescribing what they write, and find out what they write and what you think about that. Do you think it's sufficient? Do you think they're putting themselves at risk? So be very critical about record keeping. It's so valuable to you, to protect you and to protect the patient. Sometimes you may need to let other people know verbally as well. Think about the bigger picture, the team prescribing picture. Think about letting the doctor know in a particular situation. You may need to let them know straight away. You may need to let someone else in the team know straight away what you've done as well. Sometimes it's not always possible to geographically get from where you work to where the patient's doctor is and where the shared record is held. What's happening in a lot of places in the community now, there's a form or forms devised. You may want to devise one if there's not one in your area, where you can fill out all those key important bits of information about the drug, rationale, etc. that we've already discussed, and fax it through to the practice, ensuring that someone at the other end knows what this is and puts it straight onto the patient record, either scanning it in or ideally scanning it in rather than actually transcribing, with the risk of transcription errors, what you've said, so the record can be updated as soon as possible. You can't email things at the moment because of security of emails, but you can fax things.